Good afternoon, friends. And Suven, thank you so much for including me for this prestigious course and asking me to talk on IFACE. Well, as I was developing this presentation on IFACE, I realized that I really don't have those horrifying, horrible videos where there is a tsunami in the anterior chamber, waves on the iris, the entire uveal tissue comes out of through all the paracentesis and main incisions. But I realized that I must be doing something right because I must be detecting the cases well using proper surgical technique and strategy to avoid those gruesome cases where things really land you in a very tricky situation. So whenever I have a small pupil situation, I classify them into the traditional types of small pupil, conventional etiology, and the IFIS type of small pupil. So we have a list of various medications and systemic illnesses which our counselors go through and identify these patients. But I must tell you that on occasions, patients slip through this network, and we do find out when you have problems on the surgical table that, they were indeed on their IFIS candidates, somehow it was missed out. So if I am dealing with a very small pupil, an IFIS candidate, fellow I had a bad IFIS, I would straight away go and use these devices. But for other cases, other IFIS candidates where the pupil is not small, so I would use a different strategy. So what are these other cases? The dilated pupil diameter is important, and there are various studies that have shown that there is the pupil diameter of 6.5, 7, or 8 are high risk factors. Anything that dilates less than that are high risk factors for development of intraoperative IFIS. This may be cumbersome to measure the pupil diameter. So what I normally do, and another thing that is not all right with these strategies, there is a lot of individual variation, racial variation, genetic variation. So I take the intuitive pupil to pupil diameter. And let us say this case, I'm going to show you this particular case. The limbal diameter, and this is the maximum dilated pupil diameter. The ratio of this is 0.58. That's 58%, which is less than 60. So this patient might develop IFIS during the surgery. So I took him up for surgery. The usual things are you make long corneal wounds in these kind of situations. The wound should not be a borderline. The inferior paracentesis is the full MVR blade, the full incision. Superior paracentesis through which you perform your chopping and your nucleus manipulation should be small, should not be full entry, and it will be enlarged later on during bimanual irrigation aspiration if you're using bimanual irrigation aspiration. So this thing was done, and then I stay in the anterior chamber with, I entered the anterior chamber with my keratome, as you will see here, and the entry was, it is a good, normal, ordinary tunnel, long tunnel. It is nothing, it's not borderline. And after the incision was made, then I stayed the anterior capsular trypan blue dye, and the pupil starts coming down. It has already come down. So I used viscomydriasis. Some viscomydriasis also works for you to get a good rhexis, as you see here. And once you get a good rhexis, and subsequently, even if you land up in trouble, things may become still okay, manageable. So you have used viscomydriasis, rhexis is done. And before you start performing hydrodissection, make sure that you burp out the OVD from the anterior chamber. Do not overfill the anterior chamber. It should not be either with fluid or with OVD. Using the Chang hydrodissection cannula, caudate cleaving hydrodissection is performed. If you watch carefully here, the iris starts tenting out toward the incision. And as I pull out my Chang cannula, I tend to hook the iris, the pupillary margin. So I knew that I'm going to have some issues with this particular case, as you saw just now here. So started off phacoemulsification, and make sure that you grab the clear corneal incision with your tooth forceps. Normally we stabilize the eye with the paracentesis, but in this case, even if you apply a little bit of pressure, posterior pressure on the floor of the clear corneal incision, the iris is going to prolapse out. So you have to grab it and open the incision, stabilize the main incision, and start phacoemulsification. So here I created a good enough depth, and now the fluidics have to be properly adjusted. So whenever iris has started prolapsing out, if you see here, iris has prolapsed out. Here in this case, my phaco sleeve is guarding the incision, so iris cannot really prolapse out. And I ensure that you alter your parameters, and you don't want to be working with a very high IOP or a high bottle height. Aspiration flow rate also will be reasonably low. And I would not like to be injecting OVD repeatedly in these kind of situations, because I would like to finish off the phaco in one shot. Because as soon as you come out of the eye, if there is a pressure gradient, the iris prolapse will happen, and you have to think about repositing it, and it becomes a little more hassle, a little more hassles come up. So here again, it is the OVD is injected. Now, if you see here, my bottle has got exhausted, so I had to come out of the eye. So from 40 ml, now a new bottle was filled in, and I cannot see the upper part of this thing. Anyway, so the pupil is slightly irregular, and again I going with my phaco hand piece and remove. You see the way I entered the anterior chamber. So this is the way to go about it, and then consume the nucleus. So nucleus removal generally goes off pretty well. There are some subincisional areas, and you should not leave them behind. Just because it's an IFIS case does not mean that you have to ignore the other good habits, good practices for a safe surgery. So removal of removal of the cortex may become tricky. So as I mentioned earlier, my paracentesis was small size, so I just enlarged it to larger size so that it can accommodate the bimanual irrigation aspiration. So you need to expose the pupillary margin to aspirate the cortex. Don't aspirate the cortex under the iris margin. Just drag it to the center so that you will have entire cortical mass, in a triangular cortex that will come to the periphery. They'll come to the center, and then as you are seeing here, so it becomes easy for you to aspirate the cortex, which is hidden by the small pupil. As you will be seeing it very shortly here, I just engage the cortex and then I'll draw it towards the center, and then the cortex removal is complete. But then after, as you see here, now after the cortex is removed, this is IOL implantation. Again, I'm not over pressurizing not too much of OVD is injected in the anterior chamber for reasons I've already mentioned. Now here something goes wrong. I'm using a hydrophilic acrylic single piece lens, and AC is slightly shallow, and I want to avoid the iris. And in the process, I just lost the orientation in which the lens was going into the bag, and it got flipped. Fortunately for me, it is a hydrophilic acrylic lens, which is a equi-biconvex lens, and it is a 0-degree angulation. So as far as IOL bar calculation is concerned, it is not. I'll still be able to hit the target refraction. Maybe the posterior optic cage, which is has an anti-PCO effect. This is anteriorly, so maybe I can expect a higher incidence of PCO in this situation. So this is the way I ended the surgery. This was on the first post-op day, and a little bit of SKs, which is not really desirable, but that is the best that could happen. Now, this is another case of small pupil where you see I have decided to use iris hook, but I'm using a rectangular pattern of dilating the pupil. And as I start, my phaco probe goes into the anterior chamber, it negotiates the iris. So this could have been avoided by using the iris hooks in a pentagonal fashion. I am not depositing the iris from the main incision. I'm coming from the side port to deposit the iris. So initially, I thought that maybe my incision was short and I'm small size, so I having difficulty negotiating the phaco tip through that. I enlarged it, but then still the iris started prolapsing out. So finally, I created another paracentesis, another opening behind, and put in an iris hook through this. So the pupillary margin, which was prolapsing through the main incision, was hooked out of harm's way, as you see here, and safe phacoemulsification was performed. There's nothing further in the video. So this is how I ended the surgery, and the patient did extremely well. So friends, in a mild to moderate IFIS cases, you need to have a pharmacological approach towards management of the pupil in terms of whether you want to use atropine eye drops preoperatively or intracameral mydriatics. And I don't use them generally, but wound construction has to be properly done. Hydrodissection should be more gentle and slower, lower parameters, and appropriate OVD strategy. And in severe cases, or when it's very small pupil situations, I will be using mechanical devices. So thank you so much for your